Good morning, good morning, everyone. My name is John. Today we have the privilege of asking Professor Clement Lin for his wonderful talk today. Professor Clement Lin graduated from Taipei Medical University and completed his plastic surgery residency in Chang Memorial Hospital. He is currently the director of our craniofacial surgery department in Taoyuan and is actively involved in both international as well as domestic fellow training programs there. Professor Lin specializes in orthodontic surgery and the management of obstructive sleep apnea after returning from Stanford University as a research fellow in their world-renowned sleep center. Professor Lin is a student of Dr. Nordhoff and Professor Yurei Chen and continues to be a leading pioneer in the field of sleep medicine. Today, the topic of Professor Lin's speech will be maxillomandibular advancement surgery for obstructive sleep apnea. Thank you, Professor Lin.
Yes, good morning, everyone, or good evening. Today, I would talk about something about the OSA, and especially from the perspective of craniofacial development. So when we go to sleep a natural recurring state of mind and body. And when we go to sleep, the altered consciousness will change the muscle tone during our sleep, and sometimes in the REM sleep. REM sleep means the rapid eye movement. When people go to rapid eye movement, the sleep will inhibit nearly all the voluntary muscles, including our intercostal muscles. We know that intercostal muscle and some respiratory muscles help us to breathe. And in our REM sleep, there's almost only phrenic nerve that's for the diaphragm, which can help us to sleep. And the standard evaluation for how we sleep is using the polysomnography. Using this polysomnography, we can see the brain waves, the heartbeat, and the eye movement, the chest and abdomen movement, and our flowmetry from our nasal and from our oral breathing. And the other thing is the oximeter. Basically, the oximeter shows us the oxygen saturation when we go to sleep. So during the sleep, our brain wave becomes slower and slower, especially when we go to slow wave sleep. Sometimes the slow wave sleep, you can see it's almost 1 second, one wave. And another spatial stage is the REM sleep. REM sleep, it looks like the stage 2 brain wave, but the special part for REM sleep is to have a lowest muscle tone, especially surrounding our chin, our airway. The muscle tone will be very low. So during that period of time, the breathing can be, the airway may collapse much more easier than other stages. So this is a sleep diagram. In the sleep diagram, you can see there's 6 hours of recording, and the sleep structure started from wake, and then stage 1, stage 2, and here's the stage 3 sleep, and then come into a REM sleep. So we call this one from 1, 2, 3, and plus 1 REM. It's one cycle. Each cycle is spent about 16 to 19 hours. So 90 minutes. So in one night, we can have 3 to 4 cycles recording. And we can also look at the body position. The more body position changes, showing that the patient is having some difficulty going to sleep. And sometimes if there's some respiratory events, the patient will change their position of body to get into a better airway size. And of course, during that shift, the muscle tone will regain and then eliminate the obstruction of the airway. So if we look at different ages of patient and their sleep, we can see that in normal population, the slow wave sleep is getting less and less as people getting older. And for the other type of sleep stage, basically the proportion doesn't change much. The most affected by age is the slow wave sleep. We know that slow wave sleep is related to our growth hormone. So for children, growing children and adults who need some repairing for their damaged cell during the daytime, they need slow wave sleep. So if someone doesn't have good sleep, the slow wave sleep decreased and growth hormone decreased. So their growth or tissue repair can be compromised. And during our sleep, the normal breathing, usually it's a sine wave. And we know that the inhalation and exhalation has certain proportion. So when someone has flow limitation during the sleep, the abnormal contour because of the nasal obstruction or oral obstruction, the curve will change. You can see some flattening on the top of the breathing curve. That's the flow limitation. And there's also other types of flow limitation during our sleep. And all these respiratory situations are controlled by our respiratory center and reflex controls. So when we have some narrowing of our airway, the system will change the muscle tone again to get some more muscle power, and then we can have better breathing. So this is a video from the YouTube. You can see that during the sleep is quite stable. And then sometimes the flow limitation may happen in some section because of the muscle tone decreased, and then the tongue will compress to the soft palate or even the posterior pharyngeal wall. So when people have some flow limitation coming up, the brainstem or the respiratory center will start to do something to increase our airway size. So when people starting to control the muscle tone in their airway, there will appear some arousal brain waves during the sleep. So by study, actually, if our arousal frequency is more than 10 episodes per hour, then after our sleep, we will feel that we are not completely rested. So during the arousal, the heartbeat will increase, the oxygen saturation may decrease. So that's how that's what happens when people have a relative narrow airway and decreased muscle tone during the sleep. So you can also see the sympathetic tone is increased, and that's how the sleep is affected. So when we have snoring or snorting, actually it's having different meanings. When we have snoring, there's some narrowing of the upper airway. And when people have snorting, usually they previously having some stop of completely stop of breathing. That means apnea. And then suddenly the patient could have some wake up and then have the pharyngeal airway reopen. So you can see you can have a loud snoring or snorting after a long apnea. That's how we differentiate the hypopnea and apnea by their breathing sounds. And so during our sleep, if there's some stop of breathing over the nasal cannula, and also here you can see it's completely disappear. So the oral breathing will take up some of the breathing responsibility. So there's the total breathing wave through the nasal or oral is decreased more than 30%. And then you can see the desaturation here by more than 3%. That's the criteria of ASM hypopnea. And then if both the nasal curve and the oral curve disappear, so this is the obstructive apnea. So the criteria for OSA was initially reported by Professor Guillermino in 1976. And the prevalence of OSA in males and females is around 1 in 5 or 1 in 10. So patient can have so many symptoms and signs. And the issue is the apnea happens repeatedly and stop. And so, sorry. So the problem is the frequency, is how frequent the apnea or hypopnea happen. And the other thing is the narrowing of the airway space. So what matters is the frequency and the space deficiency. So the classification of OSA will based on the frequency. So in 1 hour, if the patient have 5 to 14 episode of obstruction, we will say it's mild. And more than 15, we say it's moderate. More than 30, it's severe. And the OSA coming from so many anatomical factors in craniofacial structures. So we see in our clinics that many craniofacial patients with OSA, they are having OSA because of the narrowing of their structure. When we look back to the intrauterine development of skull, we can see that from the very small one to a bigger one. So if there's any wrong happen during the intrauterine growth, the patient could have OSA at the very beginning of life, or even during the daytime, they could have something difficulty in breathing. So for this spiral bisequence patient, you can see clearly the suprasternal depression, and the patient is struggling, cannot breathe, and cannot go into sleep very stably. We know that at the very beginning of life, sleep is very important for them to have good growth. And for patients with hemifacial microsomia or Curzon syndrome, they could have airways problems due to their mandible retrusion or me-face retrusion. So for Curzon or cranial synostotic patients, you can see the complete closure of the retropalatal airway. So the closure of nasopharyngeal or velopharyngeal airway force the patient to open their mouths for breathing. So those newborn with deformities, they would need very early actions to improve their airway. And at the very beginning of their life, the cartilage still exists at the sutures. the sutures will control the growth of cranial vault and also the skull base. So when we see a patient with cranial synostosis, we not only see the deformity of cranium, but also we have to pay attention to the skull base deformity and the compromised growth, because those synchondroses among the sutures can decide the size of our skull base. And the skull base size is because skull base is superior to our nasopharynx or velopharyngeal airway. So at this part of growth compromise, the airway will be smaller than the normal child. And after that, we can see the growth of child till the adult or aged people. We can see from the lateral that in the early age of our growth, basically the face is relatively convex, and then when people grow into adult, the facial profile become more straight. And there's different period of time for maxillary and mandibular growth. Usually the maxillary will complete before 12 and then mandibular followed until the end of the puberty. So the proportion is very important because the newborn has smaller maxillomandibular portion because they have to pass through the birth tract. And for adults, the maxillary and mandibular proportion can be up to half of our total face. So the maxillomandibular growth direction is from the posterior superior to inferior anterior. So both the vertical and horizontal growth are crucial to our development of maxillofacial area. So even in homozygotic twin, because of the difference of growth, for those two twins, they can have a different condition of their airway measurement, skeletal measurement, occlusion, everything. And also they have different conditions in their sleep problem. If we look at this 2-year-old boy with adenoid hypertrophy, we can see that here the adenoid tissue is very high to obstruct the nasal passage. So the nasopharynx and velopharynx are closed mostly. So this patient was forced to use his oral breathing and then to let the air to pass through his airway. But the oral breathing has some problem. The mouth breathing, usually the air will go through the oral cavity, so the palatine tonsil will getting bigger and bigger because it's exposure to the allergen. In some experiment on primates, we can see if we close the nasal passage, eventually the primate will shift to mouth breathing, and gradually the bite will change, and then something happens. We know that the mouth breathing effect is that the mandible will relax. When mandible relax, the mandible goes backward and downward. So all the muscle tone here are decreased. So there's some vicious cycle because during our sleep, we need our muscle tones to mold our skeleton to grow. So basically, when the muscle tone decreased, the mandible will grow smaller and smaller, but smaller mandible will result in smaller pharyngeal airway. So at 4 years old, we can see this boy. It's become to have a bigger overjet, overbite, and here the tonsil is so huge to almost completely block the oral pharynx. And here you can see the nasopharynx and velopharynx completely closed. At this moment, the only thing he can do is to breathe through the mouth continuously. So what would happen when patient having this type of facial growth? So basically, the craniocervical angulation will increase and by overjet and high mandibular plane, especially the hyoid position will be relatively low compared to the mandibular plane. So this patient, poor patient, is having AHI 103. That's more than 3/4 of normal sorry. That's 3/4 of the normal, the severe OSA. So this patient, he has desaturation down to 59. The boy is struggling during the sleep. So the only thing we can do is to do the adenotonsillectomy for him. And after the removal of the obstruction structures, then he can regain a good sleep from the AHI of 101 and to the AHI of 2.9. Despite the AHI doesn't come back to normal, because normal AHI for a child should be less than 1. And the other part is the O2 saturation just coming up to 85, not higher. So basically, we should follow up this patient. But we can look at the sleep structure. Actually, the patient is getting back some good sleep during the night, and then having some good stage 3 slow wave sleep. So after a certain period of time, the patient started to have some good cycle, positive cycle for the craniofacial growth after the TNA. We can see his mouth can close to breathe, and the nose to the nasopharyngeal, velopharyngeal, and oropharyngeal airway are patent. And also the mandibular plane, the distance from the hyoid to the mandibular plane can come back to normal. And still, he has some narrowing of the upper jaw, and so the expansion can be done to improve their airway further. And sometimes the destruction transpalatally can also be done to effectively improve. And when the patient come into adult age, usually the CPAP can be considered as the first line treatment, but the compliance and the acceptance are relatively low. So there's other treatment options, such as the mandibular advancement devices or doing some surgery. The surgery can include the soft tissue surgery from the nasopharynx to velopharynx to oropharynx, or some skeletal surgery we can design for those patients. So in the goal for OSA surgery, we try to do an effective surgery. So we have to look into the craniofacial phenotypes to find out what's the real problem for those patients. Usually you can see the narrow face, especially over the middle and lower third. And then basically the vertical and horizontal growth of those patients are poor. So all the anatomical predisposing factors should be considered, including the soft tissues and eventually the tonsil. And we know that the epiglottis is playing an important role in the lower airway. And adenoid tissue and eventually the framework of the skeleton, we have to look into the structures. So the nasal resistance can play an important role because the air always goes through the nasal breathing first. So if the patient have some turbinates and internal valve, they probably need some nasal surgery. In some patients severely, they can have some collapse during their sleep. And when they open their mouth, you can see the long uvula, which has been exposed to the long-term suction power by the oral pharyngeal airway. Or you can see the narrow and high palatal vault. The palate showing us it's almost a triangular shape. It's not the round shape in normal population. So sometimes we see the scalloping of the tongue, the buccal teeth mark, and the tongue scalloping can be very severe in severe crowdedness of the oral cavity. And the other thing we have to measure is the chin throat length. Normally, the chin throat length should be more than 3 finger breadths, or even 4 finger breadths is better. Mallampati scale is an important scale for anesthesia doctor to evaluate whether the patient is having difficulty when they have the intubation. But actually, anatomically, it shows us the disproportion between the skeleton and soft tissue. When the patient is having some narrowing of the oral cavity and the proportion of the soft tissue are higher, then we can have a higher Mallampati scale. When you see grade 3 or 4 Mallampati scale, that means the patient is having skeletal problem or some disproportion. The tonsil grading 3 or 4 can show us the enlargement of soft tissue. So Dr. Freeman has mentioned about this staging quite early. Actually, it's a classification 1, 2, 3 to show us whether the patient is a proper candidate for soft tissue surgery, who is having the tonsil size of 3 or 4, or the Freeman palate's position. Actually, it's similar to the Mallampati scale 3 or 4. For those patients, they are having skeletal problem. And another population is the obesity. So when we look into those patients having OSA, they could have soft tissue hypertrophy, they could have maxillofacial issues, or they can have obesity. Basically, the 3 factors, the obesity is the strongest one, and followed by the skeleton and the soft tissue. So if someone having these 3 factors, the first one we have to treat the obesity and then the skeletal or the soft tissue. If you do it in a reverse way, usually the treatment would be not so effective. So for adult OSA patient, we have to look at the BMI to treat the obesity. And for non-obesity patient, we have to look at the skeletal phenotypes, class 1, 2, 3, and look at where the narrowest part is, and then doing the corresponding surgical design to manage the skeletal forward. And then the soft tissue, if there's some soft tissue issues, we can also do tonsillectomy or pharyngoplasty to improve their pharyngeal airway. And then if after this flow chart, we should go back to check whether the patient has some improvement or cure for their OSA. If not, we have to go further evaluation and then find out what we can do in the next. For this young male patient, he has a quite high body weight, and the BMI was 50 initially. After the bariatric surgery, he still have a body weight of 120, and then BMI 38.7. For this high BMI patient, even we treat them vigorously, the obesity could still have something there. So only thing we can do is send them for CPAP pressure, CPAP titration pressure up to 10 centimeter. Then we can have him to have a good, very good slow wave sleep. So you can see the effectiveness of the CPAP is very sure. So basically, it's always the first line treatment. And for this 52 years old male, he came to clinic with his big tonsil. We did the CT for him, and then we see that the veropharyngeal airway, the oropharyngeal way is quite okay. The facial growth pattern is relatively normal. So the only thing we do for him is to remove the tonsil, and he can have the AHI improved to normal. So for a patient having skeletal problems, such as this patient which having a retruded mandible and the narrow airway, he probably the good candidate for skeleton surgery. If we compare various surgery versus the nasal CPAP in the red column, we can see the CPAP can improve the AHI by 90%. And then the orange one, blue one, yellow one, and green one, they are all different types of MMA combined with soft tissue surgery or doing some secondary MMA. Their power of AHI reduction is quite good. And the purple part and the black part is the multi-level surgery and or UPPP simply. So when we see someone with generally narrowing of the pharyngeal airway, basically their MMA could be their primary surgery for the first time. And the effect of growth we can see here very clearly when we compare our OSA patient with retruded mandible or compared to normal breathing class 3 patients who has very large airway. And many surgeons, they mentioned about the role of hyoid bone, but actually the hyoid bone level is always around third or fourth cervical spine. And the real issue is the insufficiency of the growth of the mandible. So the lateral cephalometry can almost tell us everything. So if we compare to normal populations, the normal measurement, we can see very clearly that this patient is having high occlusal plane, the proclined front teeth, the hyperdivergent face, and narrow airway. So we have to know what is the normal measurement for SNA, SNB, and ANB, and the teeth inclination. So this polygon can show us that this normal growth of face pattern. And when we superimpose the polygon to our patient, you can easily see that actually the patient, despite of the proclined front teeth, the maxilla is still retruded. And not mentioning the mandible is so severe, more than 2 centimeter retrusion. So the MMA is a proper treatment for those patients with skeletal problem, and the successful rate is high, the cure rate is also high. And the MMA in Asia, because we tend to have a smaller SNA and SNB and shorter cranial base. So the surgical considerations for Asian population is to advance the skeletal framework more than 10 millimeter. And when we have a greater advancement from the lateral view, you can see good movement. And however, from the frontal view, you can see some negative impact on the aesthetics. including the protruded mouth, excessive teeth show, gum show, and inverted lips. So that patient, usually they are afraid of this type of aesthetic issue. That's why the segmental osteotomies are combined or recommended first by a Singapore doctor. However, he suggests some backward movement over the dental skeletal complex over the anterior segment. In our opinion, we think that may also decrease some part of the oral cavity. That's why we suggest that all the segments should move forward, including the segmented anterior segment. And we also combine with the counterclockwise rotation design for the OSA patient to have more advancement, especially the mandible part. So by counterclockwise rotation, the airway improvement, it can be 47 and 67% in the soft palate and retroglossal area. Combine these two surgical design, we created segmental maxillomandibular rotational advancement, which we use the segmental level 1 combined with counterclockwise rotation. You can see the improvement before and after surgery. The pharyngeal airway increased, and also the facial profile, the occlusion can come back to normal. So during the surgical procedure, we usually start from the mandible and then maxilla, and then do some fixation. And finally, we do the anterior inferior mandibular osteotomy. For the parietal sagittal split, we suggest using the modified Hansuk method, and that because we extended anteriorly and then preserve especially the medial gonium, because the medial gonium is the attachment of medial pterygoid muscle. The medial pterygoid muscle will prevent the distal segment to move forward or backward. So another thing is the maxillary level 1 osteotomy. The pterygomandibular disjunction should be completed by the oscillating saw and the chisel. And we have to do all the dissection completely, even for the descending palatine neurovascular bundle. We can preserve it and have the dissection out the pedicle. You can have more freedom for the maxilla to move. And sometimes the segmental design is necessary, so we can have the more advancement over the posterior segment of our maxilla. So the soft tissue protection during the surgery can facilitate the blood supply of the anterior segment. And during the surgery, we do use the single spring technique to try to move the both jaw forward maximally. This is the pharyngoscopy from the velopharyngeal airway. You can see here the upper part is the soft palate and uvula. Here is the epiglottis. And we can see the endotracheal tube is which is around 1 centimeter, and both the anterior, posterior, and lateral dimensions of the airway are increased. And you can clearly see the tongue base here. So we are very sure that after surgery, the patient can have a good airway size. And we know that the soft palate, basically, it's supported by 4 pairs of muscles: the levator palatini, tensor palatini, and the palatoglossus and palatopharyngeus. So when we move the skeletal forward, basically the support from the skeleton will provide some traction force to the soft tissue, and then both the tongue and the soft palate can be moved forward. That's how our pharyngeal airway increased. During the surgery, we also do the evaluation of maxillofacial aesthetics by these 7 measurements, which you can find in our literature. And that is the patient before and after surgery. You can see before there's almost no chin throat length, and then after surgery, the improvement of the skeletal frame and the aesthetics. After the rigid fixation by screws and plate, usually we would do some further evaluation and then decide whether we do the anterior inferior mortise osteotomy for those patients. And when we do the genioplasty, the the purpose is not only for aesthetics, but also for the traction force to the genioglossus and geniohyoid muscles. And then we can be very sure that this support will improve the retroglossal airway for a certain period of time. So after surgery, usually we use the pulse oximeter to monitor the patient's condition, and usually they could have some transient hypoesthesia of the trigeminal third nerve. Then after the surgery, the airway can be expanded, the occlusion improved, and the sleep quality can be normalized. So by the PSG result, we can see that those patients before and after surgery, the AHI coming back from 39.6 to 4 is a normal range. For a patient higher age, if they are older or obese or having more severity or the hypoglossal hypopharyngeal airway obstruction, they are unfavorable types of anatomical factors that not good candidates for may not be good candidates for MMA. So before and after surgery, usually they can have a good improvement, not only the sleep structure, and also their saturation can be improved. And concerning the facial aesthetics, basically more than 50% of them think that the improvement in the aesthetic is for sure. And none of them are asking for to putting their jaws back. So the biomechanics of this type of surgery is to move the skeletal forward, and then the oral cavity can increase. And because the muscle tone increase, the hyoid and tongue will be supported and pushed forward and anteriorly and forward and upward. So the pharyngeal airway can be improved. And by the measurement of CT, we can see that all the skeletal landmarks can be improved, especially the hyoid and epiglottis will go upward and forward. We know that the pharyngeal airway length is an important factor. When we measure the cross-section, anterior, posterior, the lateral dimension, and the area, we can see almost all the measurement can be improved, except at the level 7. The level 7 is around the uvula part. So after surgery, the AP lateral dimension increased, but the length of the pharyngeal airway is decreased. But that is good because by the law, the airway resistance is related to the airway dimension by 4, and then the airway length. If the length is smaller, then the airway resistance can be decreased. And if we compare the airway size and the skeletal landmark, we can see mostly the advancement can help the airway dimension increase, both in AP or lateral dimension. And if you want to have some index for the AHI correlation, then we can have the ASMB. When the ASMB coming up to more than 75, the AHI is mostly can be normalized. So basically, this type of surgery is for the ventilation, the occlusion, and the aesthetics. So after surgery, they can have a good skeletal framework. The occlusion is improved, and the pharyngeal airway is also enlarged. So in conclusion, the MMA surgery basically is aiming for patient having craniofacial underdevelopment and some disproportion between the skeletal and soft tissue. After the surgery, the skeletal framework can help the oral cavity to enlarge and then dilate the pharyngeal airway to help them having good sleep in the night. Finally, I would do some showing you that we are going to have the Chang Forum in November 6th and 7th, and welcome you to have registration and coming to join us in this meeting. And in this meeting, we will have much more topics, including the MMA treatment, and I will talk more about the long-term follow-ups for those patients in this conference. Thank you.
Thank you so much, Professor Clement Lin, for your inspirational talk. Do we have any questions or comments from the audience? Does Professor Zhou, does Dr. Zhou have any questions or comments?
Yes, thank you, Professor Clement Lin's comprehensive talk. I have one question is that how to, according to your statement of the pediatric, the airways, the probably is the majority be compromised by the soft tissue. So what is your suggestion for any probably if we can do something on the hard tissue to improve the airway or any other alternative treatment for that? Thank you for your answer. Yes.
Yes, for patients, a pediatric patient, if they are non-craniofacial patient, usually you can see the soft tissue enlargement. But in our clinics, usually in contrast, many of our craniofacial patients, they are having skeletal issues. So some patients, such as pure sequence, they could possibly need some skeletal destruction or very skeletal surgery at the very beginning of age. But we always considering about the skeletal growth. So we only do some action only when the patient is really having severe situations, such as screw zone patients. We could have some destruction at the very time of the age. But we can also pay some attention to those patients, non-craniofacial patient having soft tissue issues, because after surgery, we know that majority of them will have some relapse or have some residual OSA, because those patients, they not only have a soft tissue problem, but also they can have some skeletal growth compromise. Just as I shown in the slides, that young child from 2 years old to 4 years old, just because of the airway problem, the skeletal growth has been delayed because of the mouth breathing and the relaxation of mandible during their sleep. So we have to look at the whole picture of the airway, both the skeletal and the pharyngeal soft tissue, nasal soft tissue. And then we can have the comprehensive decision.
Thank you for your question and response, Dr. Lin.
Thank you.
Does anyone from the audience have any more questions or comments?
May I have a question?
Yes, please.
Dr. Lin, I enjoy your talk very much. You talk about a lot about the airway problem. You use aerodynamic to evaluate the airflow in the oropharynx. But for this kind of surgery, do you perform a virtual surgical planning for this patient to see how can we evaluate how much advance before a surgery using a VSP? That's the first question. The second question, that as for this using a VSP, we can perform a 3D management of the body structure, but the soft tissue may not be included in a 3D bony motion. How can you predict the soft tissue function during your VSP planning? The third is that sometimes we call it the multiple D, because it's bony structure change in 3D, but the patient motion with a 4D and the growth with a 5D. So it will be 5D management for all these patients. Can you explain about that? Thank you.
Oh, thank you. So the first question is about the VSP. We routinely use VSP as the method for surgical planning, and also the occlusal splint fabrication. And so the basic number for our VSP, we try to move our mandible more than 12 millimeter. Usually the patient could have some relapse, skeletal relapse, maybe 10% or 15%. So we try to move forward more, because the basic requirement is about 10 millimeter. And now we do it 12 to 14, or sometimes we do 15 millimeter advancement over the mandible. And also for the soft tissue airway, it's a difficulty part that we can simulate or understand the soft tissue responses. So we already did some study on this part, so we can do some simulation before the surgery. Sometimes we use the CT to do it twice. The first time is the normal occlusion for those patients, and the second time we can ask them to move their jaw forward to do some jaw thrust. So like this, you can see the patient could have some responses in the soft tissue airway. By these two CT images, we can measure how the airway improves, and then we can use that numbers to help us to do the soft tissue prediction. And for the long-term growth comparison, we know that the only thing we can do is to have relative long-term studies. Now we are collecting more and more data from our previous patient. In the long term, basically they would have some relapse in the pharyngeal airway. That's why our patient, maybe initially majority of them, more than 90% of them, can come back to normal range of AHI. But in the long term, they could gradually shift back to mild to moderate OSA. That's why we started to thinking whether we should totally move forward, or try to find out what kind of patient are having higher chance of relapse. So we also started to using some AI calculation to try to find out, but those studies are in progress. So maybe in certain time later, I could be able to show you some more data to understand the prediction of the MMA surgery and the long-term follow-up. Thank you.
Yeah, how is the instance of your revision surgery for these patients after your VSP?
After VSP, during the surgery, we routinely try to check whether the patient can be moved forward much more. For example, if initially designed, by VSP, we try to move 12 millimeter. And then during the surgery, we can, by single spring, we can move forward to 14 or 15. We definitely will shift to single spring to move forward much more. And after the surgery, for patient, especially for patients, old male patient or obese patient, usually they could have some relapse in the long term. So if there's some relapse in the long term, the soft tissue revision is one consideration. Or the other thing is we had some cases that we do secondary MMA. That means after a certain period of time, if their skeletal have some relapse, then we can do the second time MMA and then help them to improve the airway again. But usually those patients, the incidence of them for them to accept the secondary MMA is not so much.
Okay, thank you.
Thank you.
Thank you to both Professor Lin for the questions and response. Do we have any more questions or comments from the audience? Does Professor C.T. Chen, would you like to comment?
I have no any comment.
Okay, thank you, sir. If there's no questions or comments, does Professor Gao, would you like to do our final comments today? Thank you, sir.
Thank you, Professor Lin. And from your educational speech, we can confirm the benefit of the bimaxillary advancement in terms of is to increase the total volume of the upper airway and to improve patients' quality of life and to not only the oximetric indicator but also to improve the quality of life. And thank you for your speech.
Thank you. Thank you all. Thank you.
Thank you, Professor Gao, and thank you, Professor Lin, again for the wonderful speech. Because of time and because there are no further questions or comments, we'd like to end today's morning meeting. Thank you, everyone.
Thank you. Bye-bye.
Bye.